Hey guys, welcome again. I'm continuing with the thyroid from the general surgery, and I'm gonna do this and few other things, few other pathologies along with it. First, I'm gonna set my timer to 25. Let's just set it for 25 minutes. And yeah, yeah. The there is a vein clinical diagnostic index. It's an index basically. Yes, it's an index for thyroid to measure the thyrotoxicosis. There are signs and there are symptoms. Signs are the ones which are identified by the doctor, and the symptoms are the ones that are identified by the patient. Sorry. So, palpable thyroid is basically uh, it's noted as +3 if it's present, and its score is +3 if it's present, and if it's absent, it's -3. Exophthalmos is +2. Lid retraction is +2. Finger tremor is +1. Root over thyroid is +2. So basically, as we're going down from neck area, we're just reducing the scoring, except the arterial fibrillation, that is +4, and then pulse also it's +3. And for eye, it's +2. Now symptoms are there. If palpitation is present, then +2. Sweating is present, +3. If increased appetite is there, then +3. If decreased appetite is there, then -3. If weight is increased, then -3. If weight is decreased, is +3. And if there's preference for cold, it's +5, because in thyrotoxicosis we have these features. And if the patient has preference for heat, then it's -5. So it's a vein clinical diagnostic test, and the index suggests that if the score is over 19, if it's more than 19, that means it indicates there is, we can make the diagnosis of toxic goiter. At the index, and if the index is below like 11, means that non-toxic goiter is there. Goiter is present in either case, but we have to we should be able to tell if it's toxic or non-toxic, and vein clinical diagnostic test helps us do that. Now, thyrotoxicosis affects previously existing multinodular or nodular goiter is called secondary. So, if there was goiter in the past and now you have thyrotoxicosis, then it is called as secondary thyrotoxic thyrotoxicosis. And tachycardia with sleeping pulse rate mostly over 80 is there. Palpitation is there, low diastolic pressure is there, and high systolic pressure is there, causing increased pulse pressure and water hammer pulse. Atrial fibrillation +4. Congestive cardiac failure with ankle edema and dyspnea are the clinical feature of secondary thyrotoxicosis. Sorry. And cardiovascular manifestations are more dominant, while exophthalmos and eyesight. That's why the scoring is also low for eye signs, and cardiovascular is +4. Like the atrial fibrillation, it's +4 and 3 with the pulse and all that. The main the main approaches in treatment of thyrotoxicosis. What if suppose we have diagnosed thyrotoxicosis? What would be the main approaches? In the treatment of it. It would be anti-thyroid drugs. It could be radioactive iodine also, radioactive iodine, and there could be surgery, which is the last resort of always. Besides these, other non-specific measures include rest, sedation, and beta-adrenergic. Beta-adrenergic obvious for all the palpitation and all. There's rest and sedation also. Now, now we have anti-thyroid drugs and radioactive iodine, and we in detail we'll do all these things. Now, anti-thyroid drug, ATD, anti-thyroid drug is there. Actually decrease the formation of thyroid hormone by interfering with the organic binding of the iodine and inhibiting coupling of the iodothyroid nerve. So there's a lot going on in the thyroid gland. First of all, there's intake of the iodine. Then there is de-iod. Then there is like ionization of the iodine. Then there is organification. Then there's coupling and all of these things is there. So anti-thyroid drugs they interfere with all of these functions and it decreases the formation of thyroid hormones. The two main drugs, PTU, which is propylthiouracil, and carbimazole. Now, potency of the carbimazole is about 10 times more. Okay, so carbimazole is actually 10 times more potent, and a zero point 0.2 mg thyroxine is actually given additionally to minimize the size of goiter quickly. The way giving this to reduce the size, reduce the size of the goiter. And to counteract any chance of the iatrogenic thyroid insufficiency, the most serious complication of anti-thyroid drug would be agranulocytosis and aplastic anemia, agranulocytosis, aplastic anemia, complications, and particularly indicated in cases of small goiter, like when the patient is below 45 years, and during pregnancy also can be given. Now, radioactive thyroid iodine. It destroys the thyroid cell and reduces the mass of functioning of the thyroid tissue. It is not advised in the pregnant women, not for pregnant women. So this can be given for pregnant women, but this cannot be. It is avoided in young patients due to genetic mutation. Can cause genetic mutation. That's why it's not given in pregnancy also. Then it can cause leukemia and also like carcinoma. It's indicated in patients over 40 years. And it is the cheapest form of therapy, but there are chances of developing thyroid insufficiency and permanent myxedema also. And then surgery comes. It is a treatment of choice in big diffuse toxic goiter, toxic nodular goiter. The superior thyroid is actually ligated close to the gland because it's possible to prevent injury to the external laryngeal nerve. And inferior thyroid, uh, inferior thyroid arteries ligated away from the gland to avoid injury to the recurrent laryngeal nerve. In subtotal thyroidectomy, in subtotal, when we are doing subtotal thyroidectomy, um, we actually leave 4 to 5 grams of of uh, of thyroid tissue on each side, 1 to 8 of each lobe, that is. Post-operative complications following thyroidectomy. There could be immediate complication, there could be late complications also. So, yeah, there could be immediate complication, there could be late complication. So, hemorrhage is the one which is immediate, and infection, laryngeal nerve palsy, and thyroid crisis, respiratory obstruction, there could be parathyroid insufficiency. Late complication include the thyroid insufficiency and recurrent thyroid toxicosis and progressive exophthalmos and hypertrophic or keloid scar. Now, recurrent laryngeal nerve paralysis is actually temporary and caused by the pressure from the hematoma or edema. It usually recovers in 3 weeks. If recurrent uh, laryngeal nerve palsy is there, it will be better in 3 weeks to 3 month time. Beyond this, permanent injury of the nerve should be suspected. In case of bilateral paralysis, there is, you know, the motionless cadaveric position, and immediate tracheostomy is the lifesaver measure. Because the vocal cords will be in a cadaveric position, and there won't be any air going in or out. So tracheostomy is done. Now, thyroid crisis or storm is a severe thyrotoxic reaction that appears suddenly within 3 to 4 days of operation. So, if something is happening at 3 to 4 days of thyroid operation, thyroid surgery, then it could be thyroid storm or crisis. Okay, and it actually occurs in the thyrotoxic patient that has not been brought down to euthyroid state before the operation. So, person who is thyrotoxic should be given drugs to make him euthyroid. Then you have to go for the surgery or operation. Okay, now since this is not achieved post op, there can be thyroid crisis. So treatment mainly is preventive, और तो कुछ कर नहीं सकते इसमें. It's a big deal. Now respiratory obstruction is mostly due to laryngeal edema, and endotracheal tube should be left in place for several days, and steroid should be administered for, okay. Now damage can occur, damage to parathyroid can result in tetany. That means that all the calcium is in blood and nothing, like this hypocalcemia, da- uh, if there is damage to parathyroid gland. Majority, if the case is presenting, it's 3 to 4 days. Now the case is presenting between 2 to 5 days, same day after operation, but may be delayed for after operation. Okay, so within 2 to 5 days, but few of them, like, they occur in weeks, 2 to 3 weeks. It usually recovers spontaneously. Now there could be thyroid insufficiency. It's the most common complication followed by thyroid surgery. It usually appears within 2 years. Thyroid insufficiency. So they are the late causes. They are the early causes like damage to parathyroid, thyroid crisis, this damage. Now thyroid insufficiency is the most common complication. 2 years to 5 years. Mm. Now we can have keloid scar also because it can be avoided by incising the platysma at the level just above the skin incision. So we've made the skin incision and uh, okay. So this is our neck. If you're doing, we made the skin incision. How do we make that? I think we make it like this: skin incision, and the platysma is cut above the skin incision. That's how you don't get the keloid scar. Let me just confirm. Mm, mm, mm. Okay, I think I had it here somewhere. Can't find it. Thyroidectomy. Okay, yes. Sorry about that. Mm, I think thyroid surgery is the tracheostomy is the Fuller's bivalve tracheostomy tube. It has got no. Mm-hmm. Mm-hmm. Okay. So vertical midline. So yeah, the vertical midline or transverse incision are used in tracheostomy. So both can be used. In tracheostomy, so both can be used. Thyroidectomy procedure, the general anesthesia, supine position, sandbag under the shoulder with table tilted 15 degrees head up to reduce the venous congestion. Okay. Then horizontal crease insertion is done. 2 fingers beneath above the sternal notch and extending from the sternum. So we make the upper flap raised up to the thyroid cartilage and lower flap to the sternoclavicular joint. The fascias open vertically in the midline. And strapuses are retracted or cut to kosher. Pretracheal fascias open to mobilize thyroid. First short, a stout middle thyroid vein is ligated. And then superior thyroid pedicle is located up close to the gland so as to avoid injury to the external laryngeal nerve. And inferior thyroid is located away from the gland. Okay, where the sutured catgut so as to prevent the bleeding and drain is placed. Okay, so we don't make the skin incision that way. We actually make it horizontal. Here, make it horizontal. And then we make the cut above here in the plateau's mouth. Okay, so to avoid the keloid scar, avoid it. Yes. And now, tumors of the thyroid, it could be benign or malignant. Benign or malignant. So we have almost all benign thyroid tumors arise from the glandular epithelium and they're called adenomas. Adenomas, yeah. An adenoma by itself rarely causes hyperthyroidism. Toxic adenoma is usually part of the toxic nodular goiter other than true neoplasm. And there is histological evidence of capsule or angioinvasion and is the only reliable method to distinguish between the follicular adenoma and follicular carcinoma. So, if we have to find out between follicular adenoma and follicular carcinoma, we don't have any other method except the histological slides, histopath slides to confirm the diagnosis because it's just we can't know now. There are Hurthel cells, something called Hurthel cells or Ashkenazi or Ashkenazi or oxyphil adenoma. It is a variant of follicular adenoma composed of entirely large acidophilic granular cells. So we have follicular adenoma. It has a variant called Hurthel cells and acidophilic, oopsie, acidophilic granular cells. Granular cells are there. Um, Acidophilic granular cells are there, which are actually popularly known as Hurthel cells. Acidophilic granular cells, and it doesn't show the follicle formation. Now, malignant thyroid tumors, they can be classified as follicular cell origin, parafollicular cell origin, or non-thyroid cell origin. So they're differentiated into, if we have to differentiate this, papillary, follicular, and mixed. So I'm gonna just make a flow chart or flow diagram. Malignant tumor of thyroid. They are differentiated, undifferentiated. They come under follicular cell origin. Origin. Okay. Now parafollicular cell origin. Under parafollicular cell origin, we have medullary. My God. Medullary carcinoma. And differentiated, we have papillary carcinoma, we have follicular carcinoma, and we have mixed. And in undifferentiated, we have anaplastic. So yeah. And then there is another group like a non-thyroid cell origin. There we have malignant lymphoma, and we have sarcoma, and we have metastatic carcinoma. Metastatic carcinoma. So just to review, malignant tumor of the thyroid, we have follicular cell origin, then we have peripheral follicular cell origin. And, oops, timer. Okay, okay, cool. Just gonna do for a little bit. क्या है बाकी? Okay, we're gonna do the rest in the next session. How much? Okay, cool. Hmm.